Thank you very much. It's a pleasure to be here. A lot of what I'm going to say is going to be introductory to what I gave as my last lecture and then take it from there. You understand the fact that if you under-resuscitate a patient, they will do poorly. And if you over-resuscitate a patient, a high-risk surgical patient, they'll have complications. But that's in the operating room. In the ICU, we're worse. In the ICU, we're going to have a higher level of complications even if we do the right thing. And if we give too little fluids or too much, the balancing point is much tighter. So one clearly must be precise when giving fluids to a patient because the risks and benefits are too high and the ranges are low. So the functional questions that we would like to ask is the patient, will their cardiac output increase if they're in shock, and if so, by how much? Is arterial tone increased, decreased, or normal? And is ventricular function able to maintain that flow under pressure without failing? So if we focus in on volume responsiveness, you saw part of this picture if you were here from Paul Merrick. There is no relationship between the change in CVP and the change in stroke volume, or the change in wedge pressure to the change in stroke volume. And that's true if you looked at CVP or its change versus right ventricular end diastolic volume or its change, or wedge pressure or its change in left ventricular end diastolic volume. And there's no relationship between them and stroke volume. So it's not CVP that's the issue. As we had a debate just now, it's the issue that preload is not the issue. Preload is not preload responsiveness. Now, if you were at my lecture yesterday, you saw this picture. If you remember the cardiac physiology that you were theoretically taught when you were in school, you were told that there were 4 determinants of ventricular pump function: preload, afterload, heart rate, and contractility. These are intrinsic to the heart. We talk about preload, that is Starling's mechanism. So let me give you this example. And this is of an isolated perfused human heart published in 1959, but the data in support of this was published in 1895. So this is not new information. Here you can see the stroke volume is going down. The end diastolic volume would be somewhere here. And all they do is they simply increase the pump in this isolated perfused human heart, and you get an immediate increase in stroke volume. That's Starling's law of the heart. But watch, over time, the stroke volume remains elevated, which is the Anrep effect. And look, the preload is actually less than it was before, and the amount of time it took for this to happen was 5 minutes. And that is because when you have increased stress on the heart, it increases its intrinsic contractility. This is referred to as homeometric autoregulation, or the Anrep effect. And Starling's law of the heart is called heterometric autoregulation. If you go to any issue of the journal Circulation any month, there will be 1 or 2 papers, each issue, on the molecular mechanisms determining Starling's law of the heart and the Anrep effect, because we don't know how they work, but we do know they occur. But the reality is that's the reason why you can't use it. But what you can use is the Starling mechanism on a beat-to-beat basis. And if you're rapidly changing preload, very rapidly, and then look at the next heartbeat, as occurs with breathing or with a passive leg raise, you would see that if you have underfilled hearts and one is not so good and the other is a good heart, both will demonstrate stroke volumes that vary over a range during the breath. If you fill them up, as you know, the not so good heart won't be responsive, but over that same range, the good heart still will. Eventually, all hearts are not volume responsive. So with Jean-Louis Touboul years ago, when I was on sabbatical in Paris, we looked at not the systolic pressure, but the pulse pressure variations, maximum and minimum. Since they don't occur in synchrony with the ventilatory cycle, because the heart rate and the ventilatory cycle are not in synchrony, we averaged them over 3 or 4 breaths. And so we took the minimal pulse pressure we could find anywhere in those 4 breaths and the maximum, and we divided it by the mean, and from that we were able to look at the pulse pressure variation. And the concept behind it is that if you were to look at it, it doesn't matter the slope or the shape of your curve. In any of them, as you change your preload, if you're volume responsive, you'll have a change in your stroke volume. If you're not, you won't. And that's the beauty of this approach. And you don't need to use an arterial pressure. You can use a plethysmograph and look at the pleth variability. You can use an esophageal Doppler, transthoracic aortic flow, as shown here, and look at the velocity time index. Paul Merrick looked at all the different studies and showed that, in fact, all the pulse pressure and stroke volume studies had an excellent sensitivity and specificity to predict volume responsiveness. And then a wonderful study that was done pragmatically in Europe, in France, there were 8 hospitals that looked at everybody in the ICUs. And what they did is they did a passive leg raise, and they looked at how much the aortic velocity rose with a passive leg raise to define volume responders. And then they looked to see at all the different parameters, pulse pressure variation, velocity of aortic flow change, inferior vena cava, superior vena cava decrease, to be accurate. And the patients were breathing on low tidal volume breathing. They had heart failure, tamponade, pulmonary emboli, sepsis. It was the entire ICU cohort. And they showed a pretty darn good receiver-operator characteristic for all of them. So we can believe pulse pressure variation is very good for looking at volume responsiveness, as is stroke volume variation. But now I want to go on to the arterial tone side and look at the relationship between pulse pressure and stroke volume. As you know, for a given stroke volume, you'll generate a given pulse pressure, and if you have a lower pulse pressure for the same stroke volume, you must have a less stiff or a more compliant arterial circuit. And for the same stroke volume, if your pulse pressure goes up, you must have a more stiff or less compliant circuit. And this is just the basic principles of physics. So one can look at the pulse pressure and the stroke volume and their ratio. In this study we did in Pittsburgh, Renas Eadyn, we measured the pulse pressure before and after starting a vasodilator in patients post-cardiac surgery. And as you can see, the vasodilator increased the pulse pressure variation from 10 to 17%, that's shown on this left side. And on the right side, it increased the stroke volume variation from 9 to 15%. But what happened was, beforehand, the pulse pressure stroke volume variation was 0.14, and afterwards it went down to 0.11. We had vasodilated the patient, and that caused the pulse pressure variation to go down relative to the stroke volume variation. So I can use changes in dynamic elastance to look at the arterial tone and its response to volume. And that's important because if I have a hypotensive person and I want them to increase their blood pressure and they are also volume responsive and in shock, if you give them fluids, the cardiac output will go up, but the blood pressure may not. And so if I have a low compliance, the arterial elastance is low, even as I give them fluids and the blood pressure goes up, they're vasodilated and the pressure stays down. That's not good, because I want to get an adequate organ perfusion pressure to maintain flow to the kidneys, the heart, and the brain. If they have a normal tone, even though they're hypotensive, their pressure will rise. So one of the ways to look at it, as Maurizio Sassoni and Monge Garcia and I said in this editorial, if you were to look at the pulse pressure and stroke volume variation, you would see in this example, this person has significant changes in their pulse pressure. They have very high central arterial elastance. Whereas in this person, they have much lower central arterial elastance. The value is less than 0.77. In you and in I, our dynamic arterial elastance is between 2 and 1.2. That's normal. That's your normal dynamic elastance. Anything less than 0.9, you're profoundly vasodilated. And in fact, Monge Garcia in his study from Europe, Spain showed just this. He had septic shock patients that were volume responsive, and he asked the question, when I give them fluid and their cardiac output goes up, does their blood pressure go up as well? And as you can see, the mean arterial pressure non-responsive are on the left and responsive are on the right. And there's no difference if you look at stroke, systemic vascular resistance, mean pulse pressure over stroke volume, or mean arterial pressure. The only thing that separated out the group were their dynamic arterial elastance. If it was less than 0.9, They didn't have an increase in pressure. And that was very nice because that's what we predicted from purely physiologic principles as we tested in the lab, but we never looked at it in humans. We waited 5 years for someone to do the study. Well, it has nothing to do with volume responsiveness. It has to do with peripheral vasculature. And remember that you can't do stroke volume and pulse pressure variation during spontaneous breathing. You have to do passive leg raising. So you would think you can't use the dynamic elastance. The answer is no, because the periphery doesn't care how the stroke volume and pulse pressure occurs. It'll still be the same tone. So Maurizio Sassoni, our chairman, looked at spontaneously breathing people after surgery and found the exact same thing, that the only predictor of an increase in mean arterial pressure in response to volume in volume-responsive patients was the dynamic arterial elastance. It wasn't the actual arterial elastance, which you can measure. We have just finished a study of about 60 patients in Pisa, Italy, with Fabio Garastino, and we have found that in those septic shock patients who were hypotensive, the best predictor of an increase in blood pressure in response to fluid resuscitation was their baseline dynamic arterial elastance before getting the fluids. So again, this hopefully will be published soon, but these data support that as well. I can use that information clinically. In this study, how do you decrease the level of norepinephrine in your patient if you don't think they need it? If a person has a normal blood pressure and has norepinephrine, how do you know they need the norepinephrine? You don't. So what do? You turn it down a little bit and you look. And if their blood pressure doesn't go down, you smile and say, okay, I can do that. But if their blood pressure does go down, you're worried. Well, this group from France asked the question, can we identify when they're on norepinephrine if their blood pressure will fall if we decrease it? And they found that the same magic number of about 0.9, if your blood pressure, if your dynamic arterial elastance was greater than 0.9 on norepinephrine and you decrease the norepinephrine, the blood pressure didn't fall. So they said, why don't we use that to wean norepinephrine in our patients after surgery who have vasoplegic syndrome? You know, that's after post-op surgery. And what they found was that by using that value to decrease the norepinephrine level, they were able to get their patients off norepinephrine 4 hours sooner and had a half a day less time in the ICU. And they had no episodes of hypotension associated with weaning norepinephrine. You can use pulse pressure and stroke volume variation as surrogates of contractility because they will respond that way. In this example from dogs, Kim and I simply gave volume to dogs and we saw that the pulse pressure and the stroke volume variation decreased, as you would expect. But then in the setting of hypervolemia, we gave these dogs dobutamine, 5 micrograms per kilogram per minute in healthy dogs. And what it did was markedly increase cardiac output, but the increase in contractility returned volume responsiveness, meaning that I can use pulse pressure or stroke volume variation as a surrogate for contractility. If I've got a high pulse pressure or stroke volume variation, it means I've got a responsive ventricle because when we gave esmolol, it went away. Well, let me end by showing you a concrete example so that we'll stay on time. In the cardiac ICU at Erasmus Hospital in Rotterdam, the cardiac surgeons were worried that the patients coming back after having cardiac surgery with the left internal mammary artery to the coronary, left anterior descending, were getting ischemic. And so they asked us to please increase mean arterial pressure by 20 millimeters of mercury using norepinephrine in the immediate post-op period in the patients. And what we found was that when we did this, the cardiac output increased if the mean systemic pressure increased, it decreased if ventricular function was impaired, and we could use stroke volume variation as a surrogate. Let me show you that. We had 16 post-op patients, we increased their mean arterial pressure once they got into the ICU by 20 millimeters of mercury. In all of them, the mean systemic pressure increased from 21 to 27 because we'd increased venomotor tone. Of course, you'd expect that. Right atrial pressure also increased slightly, as you would also expect, because of the increase in venous return. And you'll note that the pressure gradient for venous return, which is the difference between mean systemic pressure and right atrial pressure, went up a lot. Arterial and venous resistances increased in all because we gave a vasoconstrictor. Stroke volume variation decreased because we had given volume in the sense of the norepinephrine. However, cardiac output fell in 10. It fell from 4.5 to 3.9. And cardiac output rose in 6 of the patients from 4 to 4.3. The patients were different. In the patients whose cardiac output decreased, their baseline post-op pulse stroke volume variation was only 9.1. They had impaired cardiac reserve. The patients who had an increase in cardiac output, on the other hand, their baseline level of stroke volume variation was 14.4. So using the stroke volume variation, we could have identified ahead of time that they could handle the extra reserve. And I get it for free. It's right in front of us. The number of devices that have it, including the ones by Edwards, because this is their symposium, are listed here. They're all FDA approved. I'm sure you've got at least one of these in your place at the moment. And the magic values are somewhere over about 10% for pulse pressure or stroke volume variation, or if you're measuring dynamic flow after a passive leg raise, at least a 10% increase in cardiac output. So to stay on time, and to allow us other time for the other speakers, I can conclude that looking at these dynamic indices of arterial pressure and flow allow insights into what's happening in terms of hemodynamic monitoring. We can actually determine cardiovascular reserve by looking at stroke volume and pulse pressure variation, or the change in cardiac output. It is a surrogate for contractility, just like the ratio is a surrogate for arterial tone. And with these methods, we can determine volume responsiveness, arterial tone, and cardiac reserve. Thank you for your attention.